in the chat box. So very quickly, Dr. Jesca is here with us, and I think it is also right that I quickly read her bio before she starts our session. So Dr. Jesca Nakavuma is a veterinarian, a senior lecturer and microbiologist at the College of Veterinary Medicine, Animal Resources and Biosecurity at Makerere University, Uganda. That's in Africa. She's a proactive lecturer and researcher with over 30 years of experience teaching microbiology-related courses at undergraduate and postgraduate levels. She has supervised over 40 undergraduate students, researchers, 48 graduate students, including 4 PhD students. She has authored or co-authored 50 articles in peer-reviewed journals, 5 conference proceedings, and contributed to 1 book chapter and 2 manuals. She is also a member on some journal editorial boards and international professional bodies, such as the International Community of Food Microbiology and Hygiene. Our research interests include microbial applications to actualize industrial applications and disease, biocontrol strategies for food security and safety. Currently PI for the AU-funded projects in Ghana and Uganda, exploring bacteriophages as biocontrol agents for management of tilapia diseases. She is also a member of the team spearheading the establishing aquatic animal health strategies in Uganda. Welcome with me to this afternoon's presentation, Dr. Jesca Nakavuma, as she takes us on the emerging antimicrobial resistance crisis in Africa, the fate of bacteriophage therapy acceptance. You're welcome, Dr. Jesca.
Thank you very much.
We can hear you, you can proceed.
Thank you very much for the opportunity you've given me. The topic I think was quite hard for me. I wish you had given me a microbiology exam. I would have performed better. But let me present what my brains came across, and you will bear with me. So the topic is emerging AMR crisis in Africa, the fate of bacteriophage therapy acceptance. And so I'll have an introduction and also look into the healthcare quality dimensions, what is expected, or the factors that are influencing healthcare, and how we relate them to the bacteriophages, the AMR surveillance and actions, research initiatives and the funding bodies, the surveillance activities in Africa, some that I could land on. How are we prepared for AMR, especially in sub-Saharan Africa? And the current status of antimicrobial resistance in Africa. Then I go into the phage therapy pros, opportunities, challenges, the regulatory frameworks. And fortunately, Professor Graham has already introduced or mentioned some of these, so it will be a walkover for me. We know that antimicrobial resistance is a global public health threat to humanity, and it is among one of those top 10. And it is projected that by 2050, we will have 4.1 million deaths as a result of AMR or resistant pathogens in Africa alone. And it has been associated with the decline of the gross domestic products by up to 5%. So there will be a financial crisis if no action is taken. The entire ecosystem is affected. We find resistant organisms in humans, in animals, and the environment. And we are sharing the ecosystem. So there is also sharing these resistant pathogens. We have limited diagnostic options as well as limited treatment options. And it has been reported that during this COVID-19 era, about 75% of the patients have been given antibiotics unnecessarily, yet we know this is one of the major drivers for AMR development. Diseases caused by these resistant bugs are becoming more deadly. We are having substandard or fake medicines in our midst. Some of the drug shops are manned by untrained personnel who are after profits and give out drugs, even if they are not supposed to be over-counter drugs. So all those practices in our midst and scenarios are increasing antimicrobial resistance, and there is need to do something. So this guy here is happy stepping over the drugs, but we have hope that we have a missile nearby that can take care of him or her, this resistant guy. The health care dimensions are usually evaluated by looking at the availability of the services, accessibility, affordability, adequacy, acceptability, and quality. All these in as much as they are looking at the healthcare service in general, but we can also relate them to our bacteriophages. Are they available? Will they be accessible? Will they be affordable? Will we be able to produce enough? Will they be accepted? How about quality in as much as the positive outcomes of clearing diseases is concerned? So, and the components of the healthcare system include service organization, the costs, users' satisfaction, and the likelihood of positive outcome. So all these, in as much as they are for the healthcare system as a whole, we can narrow down to the bacteriophages. So the global aim is to minimize microbial and antimicrobial use, because we know this is the driver for AMR development. But we know constraints of special access to drugs or access to the health services, and also the decisions taken by the patients are likely to lead to increased irrational drug use and therefore antimicrobial resistance. So there is, I think, a lot that needs to be done, not only the technical, but also socially. The global AMR surveillance system was created by the World Health Organization in 2015, and the aim was to create awareness to curb AMR. But as awareness was being created, it was realized that with systems that help in managing AMR were not available or they were deficient. By 2017, about 50% of the African countries had no comprehensive local data on AMR, yet it's data that informs on what should be done. Again, in 2017, Africa Centers for Disease Control and Prevention found need to support surveillance. They were mainly targeting serious infectious threats, but realized that drug resistance was also another serious threat. In March 2020, antimicrobial resistance was declared a global pandemic. So we are working globally. All of us contribute to the plans that are agreed upon globally in order to control antimicrobial resistance. However, there is need to build the capacity. The national action plans against antimicrobial resistance had to be developed. There is a need to mobilize resources and collaborations, because no one country can manage this problem, which is transboundary. Some of the research initiatives that are available and the funding agencies, some are funded by the World Bank. Pfizer, we know they are interested in drugs, drug development. Wellcome Trust. Framing Fund is also helping in setting up surveillance systems. And there is International Center for Antimicrobial Resistance Solutions, or so many others. I just picked out a few. And some of them, they are intergovernmental or even governmental organizations that are helping to develop or to come up with solutions to control antimicrobial resistance, especially in the low and middle income countries. Pfizer and some other agents identified about 1 billion shillings and as AMR Action Fund to stimulate new antibiotic development. But we know the challenges of antibiotics or coming up with new antibiotics. The development costs are quite high, and there is also a high risk of failure. They might come up with antibiotic, but maybe 2 years down the road, resistance sets in. There is long lead times before they can realize profits, but also the limited market potential. When they are new, they are very expensive. Are they affordable? So all those gaps can help us to push the bacteriophage application in this area. Can I see this? In 2015, there is the United Kingdom Framing Fund, which have, they've pushed out 32 country grants and 26 are currently active. And their aim is to set up the systems for fighting AMR in especially the developing countries. In 2019, Pfizer came up with teamed up with the Wellcome, and they created surveillance partnerships for improved AMR data corroboration in Ghana, Kenya, Malawi, and Uganda. And then there is a project, Erasmus Plus project of the European Union, strengthening AMR expertise in West Africa. And they aim at building capacity in carrying out the surveys, characterizing AMR and controlling its spread. In 2017, the tripartite UN agencies, World Health Organization, the Food Agriculture Organization, and the World Health Organization, World Animal Health Organization, OIE, came up together and realized that they need to promote One Health in order to tackle the problem of antimicrobial resistance. So, and indeed, they helped to come up with the documents and guidelines on how to develop the national plans, action plans against AMR, and surveillance plans. In 2007, it was realized that most African countries had developed national action plans. However, few were able to conduct effective routine surveillance. We have AMR data, but it is not systematically collected. So you find information in journals, and that was one of my major problems in addressing this topic. Some, you may not even access the national data. Some is not submitted to the supra-organized government organizations like the World Health Organization or OIE. So it is difficult to know exactly what is happening where, especially in our Middle East in Africa. So it was realized that there is low AMR preparedness amongst African countries, especially sub-Saharan countries, whereby 53% had less than the overall mean joint external evaluation score. So, and not implementing the national action plans, we were wondering whether there is interest in fighting antimicrobial resistance, or there are other problems beyond our control. And the preparedness looked at infection prevention and control, and it was realized that it was very strong amongst or within the clinical settings. Then the antimicrobial stewardship was the weakest category, I think, apart from South Africa. And was still the veterinary AMR surveillance and stewardship was less established if we compare with the clinical settings. So this calls for a multidisciplinary or One Health approach in tackling AMR, since we know that we are all within the same ecosystem. So East African countries reported the strongest AMR response, and they had developed the national action plans for the human and animal AMR surveillance programs. The high burden of communicable diseases that is in our midst, the HIV, AIDS, and so many others, results in extensive antimicrobial use. And we know this subsequently ends with resistance. So in Uganda, the whole Africa region generally, it was reported that E. coli prevalences of resistance was 0 to 87 to third generation cephalosporins, 0 to 98% to fluoroquinones. It was also almost high for Klebsiella pneumoniae, Staph Streptococcus pneumoniae, non-typhoid salmonella was bit a low, 0 to 35%. Shigella species, 0 to 9%, and Neisseria gonorrhoeae, 0 to 12%. So some are low, some are very high, but this depends on the country, depends on the study settings, and whether it is clinical or community-related infections or surveillances. But all in all, the problem is with us, and it seems to be increasing. Some studies on Vibrio cholerae, I try to look for individual pathogens, although I was not exhaustive. This was it is a report for 20 studies that were done in 16 sub-Saharan countries, and 50% isolates were 50% of the studies reported resistance to septrin, 43 to ampicillin, 43 again to chloramphenicol, and 30 to streptomycin. And also high coverage rates of the genes for extended spectrum beta-lactamases was reported in Enterobacterials, and this, it ranged from 5 to 59%, which is also a threat because these genes can be easily transmitted to other pathogens and to different hosts. So in our West Africa, moderate to high rates of antimicrobial resistance was reported in the urinary tract infection pathogens, and emerging resistance against cephalosporins was reported. They also reported moderate resistance rates among bloodstream pathogens to first-line antibiotics. So beyond these antibiotics, it becomes very expensive to manage the treatments. And antimicrobial resistance was common, particularly in the urinary tract infection among hospitalized patients. We know that patients can get nosocomial infections, and those pathogens usually harbor drug resistance genes. But the limited diagnostic capacity and second line of treatment options may affect the health or the outcomes of management of these infections. And thus, it poses a question, what options or alternatives can we have? Then in Uganda, reports from the National Referral Hospital considering the isolates from the surgical wards, reported 22% of Klebsiella, about 18 of Acinetobacter, 12 of Staphylococci, being resistant to a number of antibiotics, and the rate of the antibiotics was high. It could go as high as 100% for most of these antibiotics, but the consamides, phenicals, nitrophilans are still a bit effective, but resistance is on the rise. The antimicrobial resistance status in agriculture. We know that these are also living things. They fall sick and we have to treat them. And as a vet, that is one of my passions. Not them falling sick, but making sure they are healthy. There is limited information on antimicrobial use. And because of that, it is also inferred in antimicrobial resistance in agriculture and food production systems in Africa. There was a review that reported that about 3.5 to 4.2 thousand tons of antimicrobials were used in animals, more in cattle and poultry production systems in 13 of the 27 countries that were surveyed between 2015 and 2019. And most of the drugs that were involved are tetracyclines and polypeptides. These tetracyclines are used against bacteria as well as protozoal diseases in domestic animals. So unlike the farm animals, there were a few studies in crops or crop production, fish and beekeeping, but those few studies also reported some resistance. Mild drug resistance of 0 to 100% was reported, but this depended on the country or differed by country, the antimicrobial agent, the type of pathogen, and also the production system. But having mild drug resistance is another very big threat to management of diseases. The lack of surveillance in agriculture and food production system makes it difficult to ascertain the trend of antimicrobial use, as well as resistance and policy enforcement, in as much as regulations exist, is also weak. So we have those challenges that can affect management of drug resistance in the animal production systems and the crops. So there are several approaches that can be used instead of bacteriophages. We've realized, instead of antibiotics, we've realized that the resistance is quite high. That means that we should have, so there are some botanicals that are being explored, the probiotics, but we also have bacteriophages, which is our interest. So bacteriophage therapy, some define it as application of bacteriophages as antibacterial agents, which is quite broad. When we are aware there is therapeutic use versus non-therapeutic use of bacteriophages. So whether phage therapy fits only for the therapeutic use, or it can also be applied to non-therapeutic use, I think that is a debate amongst us, and we should come up with a clear, we agree on a proper, on a definition. So as Professor Graham stated, phages are potential alternative or synergistic agents to antimicrobial therapy. So we are aware in as much as phages have antimicrobial resistance, but by themselves, they may not be able to clear the infections. So they need to be like potentiating the activity of the antibiotics. So if we are to exploit the bacteriophages, because our worry is the challenges in introducing them in our midst, I think we have to exploit the advantages. We have to desensitize the various stakeholders in relation to the advantages of the phages, and also the situations that warrant exploitation of the bacteriophages. And once we've created awareness, I think the other technical hitches in having the products availed can be handled. Since other nations have managed, we can learn from them. So the advantages is that the phages can be considered as self-replicating pharmaceuticals. So since they can multiply, there is no need for repeat dose as it is for the antibiotics or the chemical antibiotics. But there is complicated pharmacokinetics. We don't know what happens, or we may not know what is really happening when these phages have been administered, especially if they are given systemically, not matically. Then the specificity. So we explore the specificity that there will be no effect on the microflora. Indeed, phages have been utilized as probiotic supplements, like in management of Clostridium difficile, leaving the gut flora intact or undisturbed. The other advantage is that they can also lyse the drug-resistant bacteria, and there is no species barrier in antibacterial activity. So a phage that is killing pathogens may be obtained from animals can also kill pathogens obtained from the humans, as long as that pathogen is sensitive. So the same phage bank can be relied upon to develop products. The only disadvantage that we have, we should know the disease agent. We cannot treat blindly like it is for the antibiotics. Then the other aspect is safety and immunogenicity. Again, Graham mentioned something about this, the immunogenicity. The phages are ubiquitous. We eat them with the salads. They are within our intestinal tracts and those of the animals. So they are everywhere and there is constant exposure. So because of that, and in addition to their specificity, we consider them to be safe. And also when they get into the body, in as much as they are not highly immunogenic, but they are foreign agents. So an immune response can be, has to be mounted. But these antiphage responses can influence the route of administration, and they can also affect the efficiency or the efficacy of the phage treatment, but they may not be of too much of safety, although it is thought that they may lead to hypersensitivity reactions. And because of that, many of the phage use, especially in the humans, has been topically or orally, not through injections, because of these antiphage responses that can affect the activity of the bacteriophages. And then some bacteria it's thought that they can develop resistance to the bacteriophages, but also some bacteria form biofilms. And we know that biofilms are more or less of phenotypic resistance, mechanisms of resistance. But since bacteriophages can penetrate through the biofilms, the enzymatic degradation that takes place can be exploited in as much as you are not applying the phage particles, but we can get the phage products or the enzymes to work on the biofilms. And for the bacteria developing resistance, the phage cocktails can work. So that means one has, if there is a product, one has to know what are the circulating bacterial strains, and they are sensitive to the existing bacteriophages. And if none, they are not sensitive to any, then we can get more and add on, but depending on the regulations. The opportunities for phage therapy exist. I think we are more or less in or entering a post-antibiotic era. So if there are no antibiotics, we will have to get something to help on the management of health. There has been success stories where bacteriophages have been used to manage diseases in humans and animals. So several stories exist, or many stories exist. Before antibiotics were discovered, and now we are getting a lot of literature on this. So we can also ride on these success stories and build a story or reasons as to why we should have phage therapy in our midst. There is prohibited routine use of antibiotics in farm animals. So what alternatives do we have? Because it's thought use of antibiotics in animals is one of the major drivers for antibiotic resistance development. We have to, this one is in our midst. So it is an opportunity, it is a problem, but it is an opportunity we can explain better. Preference for chemical-free foods. There is a craze for organic foods. So I think bacteriophages can come in very well. Again, drug residues in food animal tissues. If we use antibiotics, we have to observe the withdrawal period, which is not the case for if phage therapy is made use of. And we know that drug residues affect trade. So much of our products do not pass for export because of the drug residues that are used during production. Another opportunity is that phage production is quite simple, economic, and the wastes from the production processes are biodegradable. So it is stated so, but when it comes to products for use in humans, it might be a little bit more complex. Maybe if we are applying to crops in the field out there, it may not, it is likely to be a little bit easier. Then when we look at environmental impact, whatever we do these days, there must be an environmental impact report. So since these phages are already in the environment and in smaller numbers for a specific host or bacteria, when the waste is released, we could be scared of ecotoxicity, but it can only occur on potential phage host, and which phage host we are most likely interested in getting rid of. So, and because of the specificity, others will not be affected. So there is minimum environmental impact when phages are used. For therapeutic use of phages is reported in humans and animals, and preclinical data exists elsewhere, not really in Africa, but the therapeutic products on the market do not measure up to the data that exists. And the lack of clinical trials performed under Western regulatory agencies or existing regulatory drug development regulations cannot, are hindering having these therapeutic products in place. And as I mentioned earlier, we can use phages in combination with other antimicrobial agents, but still you need clinical data for these bacteriophages. So use in livestock or in agriculture may be a bit easier because maybe the regulations may be a little bit mild, and but they've been used to manage production diseases with the aim of improved productivity, but also food safety and also to manage the zoonotic pathogens that can be transmitted via the foods. So non-therapeutic uses in foods, agriculture, and for plant protection exist. And this is because there is reduced regulatory burden, lower development costs, and faster time to market. Indeed, companies that had gone into, not in Africa, of course, that had gone into production of therapeutic products for humans realized they could not meet the requirements, and it was easier for this non-therapeutic use. And as a result, there are several phage products that are on market used for non-therapeutic purposes. And for food treatment, the United States Food and Drug Administration granted generally recognized as safe status for phages for food treatment. And there are several products that have been approved. So when we are looking at non-therapeutic uses, we have phage therapy in animals for pre-harvest pathogen control. Within maybe we add in the feeds. Then we have biocontrol post-harvest used as sprays on the after slaughter or during slaughter or on harvest crops to reduce or remove the pathogenic organisms. Biosanitization, like maybe in the processing plants, but also in the animal houses. And then biopreservation, some have been, instead of using chemicals to extend the shelf life of the foods, so phages can be used in taking care of the microbial contamination and therefore microbial spoilage of the foods. So I got this from a certain article. I don't know whether I quoted it, but there are a number of companies in the Western world, in Europe and USA mainly, but also in China, that are producing products that are available for non-therapeutic use. And they are taking care of food safety. The ones in, there are also those that are used on plants. Some are taking care of the soft rots or even the plant diseases. So however, we have challenges to phage therapy. These challenges are experienced in the Western world as well. And I think it could be worse in our settings due to the limited technology or tools that can help us to circumvent or even identify those challenges. We know that phages play a role in genetic transfer, and that knowledge alone can affect acceptance of the bacteriophages. So there is need for sensitization, there is need to scrutinize the phages and confirm that they do not have capacity to transfer genes. Then we have limited knowledge on phage kinetics. In vitro, we may get the information, but what happens in the body, we may not know. So there is need of much research, especially maybe in experimental animals, to know what is really happening when the phages are introduced. Where are they distributed, or where do they concentrate? Are the numbers increasing or not? Is the immune system taking care of them or reducing their activity or not? And this, of course, will be a regulatory issue because that information is needed before a product is allowed for use. Then there is the issue of their safety. In as much as we say they are highly specific and they cannot affect the human cells, animal cells, and so on. But when they act on their gram-negative hosts, endotoxicity has been reported. So this endotoxicity can be probably in the product, endotoxins can be in the product, so there is a need to purify, or it can happen during treatment if it's the gram-negatives, the organisms that are targeted within the body. Then another one is the regulatory frameworks. What should we follow if we are to carry out clinical trials or the procedures? Are there appropriate guidelines in our midst, or we have to borrow from what exists elsewhere? So that is acceptable, but again, it needs that those guidelines are incorporated into the national ones. Commercialization is the way to go if we are to go into availability, sustainability, and the public-private sector partnerships is very important. Researchers do not have facilities. We do not have the facilities for production. There are maybe biopharma companies within our countries that we can look up to. There is the issue of patentability. Patenting phages, which are natural agents, is not easy. You have to patent maybe the formulation and so on. But if the private sector knows that there is no, maybe it may not be patent, it may not be able to patent, there is then the profitability, their willingness to invest may be compromised. However, companies have invested in for phage production for agricultural applications. Then we have the consumer perception. I mentioned that we have to use the advantages of phage therapy to convince the community. But people hearing that viruses are in foods to control maybe the pathogens, one might think twice to purchase such a food. So we need to know how to package our information and such that it is not alarming. And also to see whether we can have alternatives. We do not have whole virus particles in there, but maybe there are products like endolysins and so on. But the possibility of us having endolysins and purifying them, all those are more challenges that we are facing. So the regulatory framework. So in Africa, the countries, almost all the countries have national medicines regulatory authorities are referred to by different names. Originally, these authorities were after patent protection and trade promotion. Product safety came in later. But currently, their mandate is much bigger than all this. It includes marketing, it includes monitoring, pharmacovigilance, and so on. In the majority of the countries, they all report to the Ministry of Health. And it seems the Minister of Health has overall responsibility. So we must have a way of getting to these people, convince them about phage, and such that they buy the innovations associated with the phage therapy. Some of these countries have the policies or develop the policies or provisions for the policies that deal with the traditional herbal medicines. They also have mandate to control veterinary medicines. Some regulate various other products like the foods, poisons, pesticides, water, cosmetics, food animal products. So where do the phages fit in? Are they herbal medicine, traditional herbal medicines? Not really. And it might be difficult to have where they fit best without modifying some of these regulations. So where do we fit in? Where do we start from? I think sensitization of these authorities is quite important. And they are also, like in Europe, they talk of phage being considered as phage therapy, to be considered as phage therapy medicinal products. But they are unconventional, and there is variable qualitative and quantitative composition, which is required for the medicinal products. So again, they may not fit very well in there. But also the intended use can make it easier, compassionate use. We can go for the declaration of Helsinki, and the use of defined cocktails or the custom phage cocktails for specific patients. So again, permission has to be sought before we use these phages. So there is lack of well-defined regulatory pathways for phages. And it is more serious if they are to be used therapeutically compared to the non-therapeutic uses. So guidelines exist, like in the United States Food and Drug Authority, the European Medicines Agency. They have some guidelines which are enabling them to apply or use some of these phage, the phages that are available. But in most cases, there is need for large-scale clinical trials. And I read somewhere some of the clinical trials that were carried out, like for cholera in India, were ended prematurely because the control groups were getting serious adverse effects, so they had to get the treatment. So, and then we also need good manufacturing practices, cell banking. Do we have the capacity for the phage banks and their host cells? Testing raw materials, process controls, product characterization. And in addition to good manufacturing practices, we should have sequence data, which is very crucial for quality control. So do we have the capacity for like a whole genome sequencing? It is becoming cheaper, but you might find that probably in your institution or in the country, not very many of those services are available, and where they are available, they are more expensive. So making it more, again, unattainable on our bit. So from all these regulatory frameworks and where it has been used and the advantages, and that's where we can draw lessons and see how best we can probably realize application of bacteriophages in our midst. But as it is, we still have some bit of challenges which we have to clear. I do not have a slide for challenges as such, but as I was going through, I could bring it out here and there. So the fate of bacteriophage acceptance, where do we start from and how? In my view, we need to collaborate for those who have already gone through it. So collaborations with our fellows in the Western world is the key to go, and even collaborations within amongst us on the continent. Some institutes have certain facilities which we can make use, but as it is, even moving materials within Africa is not as easy as we might think. So I'm on the committee of this journal, Phage Therapy Applications and Research Committee. Please, when you have your phage research that you need to publish, the journal is available for us. You can go look it up and get more information. So I thank the webinar organizers, the funders. I thank my Phage team Uganda for their contribution to what I had to present. The audience and all of you, I say thank you. Aruta Continua, this was one of our very first phage work. You can see how untidy it is, but we moved away from that. So that's why I'm saying Aruta Continua. Thank you very much.
All right, thank you so much, ma'am. I mean, that was an amazing session. Please, if you have questions, please kindly put in the chat box very quickly. Still have a few minutes left. All right, thank you so much, my Dr. Jesca. So I have a question here in the chat box. It says, thank you, Professor Jesca. The question from you says, in your expert opinion, can phages play a role in preventing disease outbreaks of bacterial origin, for example, cholera?
Thank you very much for that question. When an outbreak has occurred, you have to move very fast in order to contain it. So there are various steps that are taken. So phages by themselves may not contain, but if we swing into action, probably to identify the contaminated water bodies, which is usually the source, and maybe treat such water with the phages. And yeah, we can contain, but not phages by themselves, because that is usually a stressful situation when an outbreak. And you know how fast cholera spreads.
All right, thank you so much, Ma. Okay, there's another question here that says, since we do not have guidelines for commercial phage use in Africa currently, can approval from bodies outside Africa suffice? This question is from Ivy Chimoa.
Thank you very much, Ivy. Approval from outside Africa may not suffice, but it may lighten the burden. And you introduce that, because like if a product has been passed in the US, so it can easily be maybe evaluated in our settings and utilized, but still you have to get clearance from the relevant bodies before you use them.
All right, thank you. Okay, I have another question here from Noting. It says, building on quickly one of the questions addressed to Professor Hartful, are African phage researchers now ready to set up transmission electron microscope facility?
I think that is an important equipment that we feel we should have, but I think even in its absence, if you do whole genome sequencing, you can move some steps forward. But in Uganda, we have an electron microscope, but it is a scanning microscope, electron microscope. So it's better than nothing. And but as I said, that moving materials across countries within Africa is not easy as well. However, maybe if one has prepares the bacteriophages and fixes them on a grid, then maybe there you can move them easily. But we have to know which institutions have got the transmission electron microscopes, their willingness to team up with us such that we can access that, that facility at a fee, but that fee that is affordable in our midst. I think that is one of the way to go. And I think maybe as the African Phage Forum, we need to document who has what in order to draw or to use such services.
All right, thank you so much, Ma. I think in Nigeria here also, I believe we have an electron microscope, although I think our faculty team will be able to answer more of that. But I agree that we should actually have a documentation of what kind of equipment Africa has. So I'm going to be taking, say, one question before we round up. So I'll just say, this question is from Victor. It says, without successful clinical trials in Africa, will it be possible for phage therapy to be approved?
Phage therapy for animal use can easily be applied. But for the human use, we still probably go for the compassionate use. And we have also to see what our regulatory bodies have and where we can fit in, because there is no way we can introduce them anyhow. But since we have, how would they call it? The herbal medicines being used, but still the herbal medicines clinical trials are going on. We should see how best we can introduce phages for clinical trials. So it is still an uphill task, but since others have managed, I'm sure we can also manage.
All right, thank you so much. I think if there are any other questions, please kindly.
There is one I see from Olamide.
Yes, Rakib. Okay, yeah, it says the economics of scale of using phage in both therapeutic and non-therapeutic application is really interesting. In your expert opinion, what do you think the role of science communication would be in reducing consumer anxiety? Okay, please, very quickly, Ma.
Yeah, thank you very much, Rakib. Yeah, we need to communicate because everything new to us makes us anxious. So I'm sure we've all experienced with the SARS-CoV vaccines. I don't know the acceptability in your own countries, but in ours, it has been an uphill task. A lot of communication has to be done. So, but there are some people who are more knowledgeable in communicating such information in a subtle way that will not cause panic. Because if I just go and say bacteriophages are viruses that eat bacteria and they've been introduced into the food, that I've already killed the initiative. So we have to get a subtle way of sensitizing and also communicating the information to reduce this anxiety. So science communication will definitely do a very big role.
All right, thank you so much. In fact, that is a very interesting perspective. And I believe that would also be addressed in tomorrow's sessions. So on this note, I would like to say a very big thank you to Professor Jesca Nakavuma. Thank you for this amazing session. I believe a number of us have learned a whole lot. And if we have any more questions, please, the team mail has just been sent into the chat box. That's at Ibadan Phage Research Team at gmail.com. Kindly forward your questions to the mail and then it will be directed to Professor Jesca, and you'd get a response. So on this note, I would also like to thank our own daddy here, our father, and that is our faculty team head, Professor George Ademowo. I would like to say a big thank you. He has been around since the beginning of this conference and is still around. Thank you so much, sir. Also, I'd like to say a huge thank you to our other faculty team here. I can see Dr. Solomon Bakri, Dr. Adewumi. I can see a member of the departmental staff, that's Dr. Bamishaye. Thank you so much. And of course, I would like to say, I mean, this conference would not be a possibility without our sponsors, our very own sponsors, and that is Phage Directory. I would like to say a very huge thank you to Jessica Sacha. Thank you so much. And Jan Zeng, they are the host of this meeting. They are the ones running the technicalities of this conference. A huge thank you to Baylor College of Medicine. Thank you so much. And of course, Phage Directory for the wonderful support. Of course, this conference does not end here. We are also going to be having 2 more amazing sessions tomorrow. By 1 p.m. Nigerian time. Of course, the time has been sent to our various emails, and I think a reminder would also be sent. And before I round off this meeting, I would also like to say that the team, that's Ibadan Bacteria Phage Research Team, the host of this conference, will be launching our very own premier journal, that is the Familiar Journal, on Monday, November 1st. And I would just like to just share a screen of a snapshot of the cover page. If we can see our screen, this is the Familiar Journal cover page, and it's going to contain very educative and very amazing content. It's going to be launched, and of course, it's going to be uploaded to the team website, and I think everyone will be notified on their email address. So on this note, I would like to hand over to Dr. Jessica Sacha as we round up today's session.
Thank you so much. This has been great. Thanks everyone for coming. Yeah, we'll see you tomorrow. You'll get another email for another reminder, and a note that we have YouTube live streaming going on in case there's overflow. So you can watch it there as well. So yeah, see you tomorrow.